We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, Jesse, what is new in the Northeast?
Well, spring is slowly springing, although I see a forecast for snow this weekend. But I am looking forward to seeing the grass turn green and the flowers popping up.
Yeah, absolutely. Hey, speaking of spring flowers, do you know what types of flowers bacteria like?
I don't.
Geraniums, of course. Oh, it's always a riot here. Well, we're going to have a riot today. It's going to be fun, Jess, because we are talking with Dr. Mona Krouss and Dr. Harry Cho about their research article, Choosing Wisely Initiative for Reducing Urine Cultures for Asymptomatic Bacteriuria and Catheter-Associated Asymptomatic Bacteriuria in an 11-hospital safety net system. Today, we are talking with Dr. Mona Krouss and Dr. Harry Cho about their research article, Choosing Wisely Initiative for Reducing Urine Cultures for Asymptomatic Bacteriuria and Catheter-Associated Asymptomatic Bacteriuria in an 11-hospital safety net system. Now, Dr. Mona Krouss is the Assistant Vice President for Value and Patient Safety for New York City Health and Hospitals, which is the largest municipal healthcare system in the U.S. She's also an assistant professor of medicine and practices clinically as a hospital at Elmhurst Hospital and Mount Sinai in New York City. Dr. Krouss's research involves the intersection of overuse and patient safety and studies the downstream harms of unnecessary tests and procedures. Her work has been published in AJIC, JAMA, Internal Medicine, Journal of Hospital Medicine, among others. She is a certified patient safety specialist and was recently recognized by Becker's Healthcare as a top patient safety expert to know in 2022. And Dr. Harry Cho, MD, FACP, SFHM, who is the Vice President of Quality at Brigham and Women's Hospital and faculty at Harvard School of Medicine. In the past decade, Dr. Cho has received over 70 awards and recognitions for his leadership, including Top 25 Innovators by Modern Healthcare, and was recognized in 4 national under 40 lists: Becker's Hospital Review, National Minority Quality Forum, Modern Healthcare, and Medscape. He strives to improve outcomes across complex healthcare settings through developing innovative, scalable solutions. His research focuses on the intersection of overuse and patient safety and aims to eliminate unnecessary testing and treatment that cause physical and financial harm to patients. Welcome to the show, Dr. Krouss and Dr. Cho.
Thank you.
Thank you for having us.
Oh, our pleasure. We are thrilled. It's going to be a lot of fun today because as infection preventionists are well aware, urinary catheter or Foley use for patients can have significant downstream effects for both the patient and the hospital. And Drs. Krouss and Cho, can you give us some background on what prompted you to do the work described in the research article, and how did you select the locations?
Yeah, it's interesting. Harry and I are not infection preventionists. We're actually hospitalists. But as a hospitalist on my rounds, I noticed that my residents were consistently treating urinalysis that didn't have bacteria or urine cultures without symptoms. And it seems like no matter where I've worked, that this is a really common problem. So that prompted us to look into it further in our own system. And we chose the 11 hospitals because our system, New York City Health and Hospitals, has 11 hospitals in its system all across New York and the boroughs.
Hospitalists are some of my favorite people, actually, just so you know.
Great.
Good to hear.
We have a really fantastic hospitalist that worked really closely with our infection prevention team and I like to call him the Foley whisperer. Getting those Foleys out. Woo! So in your article, you describe asymptomatic bacteriuria as a cause for inaccurate urine culture results and inappropriate treatment. Can you define asymptomatic bacteriuria for the listeners and tell us why this occurs and may be more prevalent in patients with urinary catheters?
Sure. So asymptomatic bacteria is basically the presence of bacteria in the urine, but you don't have any symptoms of urinary tract infection. So you don't have burning or pain, and it's very common. And unnecessary treatment can actually lead to antibiotic resistance. And of course, when you're getting antibiotics, there's so many side effects that you can get from antibiotics.
So what's triggering providers to order a urine culture? Like in my experience, for asymptomatic bacteria, people would order it for reasons such as like cloudy urine or something like that. So can you explain why these, quote unquote symptoms don't necessitate a urine culture and what might be triggering it?
Sure. I could take a crack at this one. I think sometimes it's a little bit of a habit. Particularly when there's a fever in the hospital or SIRS or sepsis going on that's suspected, there's this thought of making sure that you have all the tests before you start antibiotics. And sometimes through that process, people want to be a little bit more comprehensive than not. And people start drawing, urine cultures, blood cultures, a chest x-ray, or anything else that possibly could be suspicious.
Mm-hmm. Pan culturing.
Exactly. And that's what ends up happening. And so from that, you can see a lot of the downstream effects and the false positives that come up. And so that driver, I think, is difficult. And then from a, ED and a hospice perspective, sometimes before you make that next call, so if you're in the ED and you're making that call to the specialist or to the admitting team, sometimes the questions come up, did you order this? And sometimes it is a genuinely honest question, but sometimes that it gets perceived as, oh, we should have ordered it before we made that call. And so those things kind of drive that behavior.
Okay. Yeah. Well, let's dig into the study interventions now. So the first intervention, an indication for urine culturing, was required beginning October 2021, but the best practice alert to alert ordering clinicians of the high rate of ASB wasn't implemented until December 2021. What was behind that timeline?
I'll take a crack at it first. I think, a lot of these things, for quality improvement, which is the world that we live in, and then also COVID and the surges that would happen in the, public health system. I think sometimes, things go in whichever sort of fashion that the world deems itself. I think, we were trying to do it as quick as possible. When we had sort of the cadence of surges and situations. And I think we just tried to do the best we can. But ultimately, I think we were very happy that the first and the second intervention happened as quickly as possible. And then from whatever ended up happening, we could sort of draw some conclusions.
I think this is really great. So the first mandatory intervention encourages the providers to only order urine culture on symptomatic patients. Does the EMR provide a list of those symptoms? And if so, where was the list derived from? I'm just curious if they align with the NHSN definitions, which are used for which the study used for the outcome measures, or something else.
Yeah, that's a great question. We tried to align it actually with the IDSA criteria, but it does include things similar to the NHSN definition. So it has dysuria, flank pain, suprapubic pain, hematuria, and then we added fever without an alternate source identified or altered mental status without a source identified.
Great. And so for that second intervention, the best practice alert was used. And in my experience, there's been a lot of hesitancy around using BPAs due to like BPA fatigue. Can you tell us how the BPA worked and if you received any feedback from clinicians after the BPA was instituted, negative, positive?
Well, for the BPA, You're right. It leads to this concept called alert fatigue for a lot of providers, and you think that it's just one more click, and so it wouldn't be that bad. But I think cumulatively over time, it's sort of wore down our providers. As they're sort of going through their day. I think anyone who's a provider has sort of understood this. What we try to do is minimize the number of false positive triggers. So make it pertinent for the situation at hand. And the biggest premise that we wanted to focus on was the indwelling Foley catheter. We know that when there's a Foley catheter that's been in the hospital, not on admission, but after 48 hours or hospital acquired, sort of the longer you stay in the hospital with a Foley, that it's going to become positive whenever you draw urine. The more there's a steady rate that it increases. And so when we did this, we wanted to sort of avoid that, to make sure that the providers can sort of understand just at the point of point of ordering, that the incidence of asymptomatic bacteria is really high. So make sure that you really sort of gather whether they are symptomatic before you order. And so that's what that BPA was for.
Oh, yeah, I like it. And speaking of that, the article describes the use of a nudge to kind of influence those ordering clinicians. So let's talk about more about that, if you don't mind. What the nudge was, why it was used. Do you think it impacted clinician behavior?
This is one of my favorite things I've done at New York City Health and Hospitals, was just gathering together with Mona and trying to strategize how we can sort of improve our intervention. So nudge is a concept from Thaler and Sunstein from their book. And it's a way, the way they describe it is any choice architecture that influences predictably human behavior without restricting options or giving any financial sort of incentive. And so these are sort of gentle nudges, or what we sort of see is these gentle nudges actually lead to an incredible change in behavior.
Okay.
So we like this. And so, one of the concepts, there's a couple of different nudges that we used here, but one of the things is sort of the paradox of choice. So whenever you're ordering a whole bunch of urine or a urine culture, so there's a lot of indications for when it's appropriate. And so when you list all of them, a lot of times within the EMR screen, you'll have 10, sometimes 15 different indications that people sort of list on. Mm-hmm. That overwhelms the user. Mm-hmm. As smart as we are, as we're going through this, sometimes when you have a whole bunch of info or choices, it just becomes overwhelming. The parallel is, if you go to a grocery store and you're trying to buy a ketchup from one of the aisles, if someone goes over there and they see 15 brands or 20 brands of ketchup, what ends up happening is they look at it, they get overwhelmed, they won't even buy it, they'll just walk away.
Same,
but if you have if you have 5 or 6, then you're more likely to buy it. And I think about that, and I do the same thing. If I go to a restaurant and there's a whole bunch of things for wine, I just get overwhelmed. Like, I don't want to do this. Right. And so this is the concept that we use. And so we limit it to 5 or 6, and that seems to work well in terms of honing them in.
Human psychology.
Mm-hmm. Yes.
Yeah, so that's funny because actually one of my colleagues and I were just talking about this morning about this article, and we were talking about how we need to, there's so many things that we have to keep in our mind all the time, and if we can sort of help people make the right decision, put things in place to help them, then it makes it like one less thing for them to think about and have to come to conclusions around when it's sort of laid out in front of them. So I love this concept.
Yeah, it's one of the benefits of an electronic health record. There's pros and cons, but I do think that the EHRs make decision making a little more. It's helpful. You have a lot of information at your fingertips. So yeah, it should help clinicians. And I like the nudge. I thought that was a really neat intervention.
Yeah, and I love the interventions like this, and I love talking about them because I don't think everyone has quite grasped all of the opportunities available in the EMRs, Nikki, around like how you can optimize it, the use of these interventions and BPAs and things like this to get, the outcomes that you are looking for.
Right. Yeah.
So, following the initiation of these interventions, what outcomes were measured? The article notes that there weren't audits, education, feedback included as part of the study. And, we hear all the time, if something isn't coming out the way we want it to, re-educate, re-educate, re-educate. So, why did we choose not to include these in the project?
Yeah, that's a great question. So, I think there are times and places to use audit and feedback and education, but when we're trying to do an intervention across 11 hospitals, it becomes really difficult to scale that. And we know that we need education, but we have to continually re-educate, like you're saying, and it's just not sustainable in most cases. So the beauty of an EHR intervention is that it goes live immediately. We build in the education there, and then there's no maintenance. So
Love it.
it just stays there. It does, it does its thing. It keeps working. So I think audit and feedback and education are best when you're doing single unit interventions where you can really control who's there. But when you're trying to do scalable projects, I think the EHR is the way to go.
Yeah, you got to make
Can
it
I-
easier. People won't do it. Yeah, sorry, Dr. Cho.
Yeah, no. I just have a fun story. So I switched institutions. So I was working right next to Mona, and then I came up to Boston and I'm at the Brigham. And my first day, just a funny story, I walked into the office and there was a bunch of people around, and I found out they were project managers. I actually didn't even know that they reported to me on my first day. So I found out there was 8 of them. And then, of course, I had a huge smile on my face. I'm like, oh my gosh, there's so many project managers here. So, of course, I go back to, the people that I know at health and hospitals and the safety net system. And I'm texting the chief medical officer to be like, hey, I have 8 project managers. What do I do with them? And this, which is a good problem to have.
Yeah.
And it was more of a joke. But, if you think about this, the safety net is very different from a major academic center with NIH grant funding with, project managers like this. And so from Mona and I think one of the big things that we wanted to focus on is like we are understaffed. We are, there is high staff turnover. We are in the middle of COVID. What can we do that is high impact with low effort, that is meaningful and really prioritizing our efforts? And so, yeah, I think this makes sense.
Yeah,
That's awesome.
It is. It's smart. It's very smart. So, following the initiation of the interventions, across all hospitals, the BPA was triggered 4,822 times and accepted, meaning the urine culture was canceled, 552 times, which was 11.4% of the time. So, what kind of impact did this make on the overall urine culturing and urine culturing of patients with urinary catheters?
Yeah, that's a great question. So, in our results, we saw that patients with urinary catheters, the urine cultures were decreased about 22% of the time,
Great.
which is lower than the BPA accept rate of 11.4%. And we've noticed this phenomenon in a lot of our projects. And basically what we think is happening is that the users are learning over time not to order the urine culture. So they order the urine culture, they get the BPA that says, you really shouldn't be ordering that. And then they learn not to do it the next time. So the BPA doesn't come up. So that's what we think is happening.
So they're just trying to avoid the BPA.
Yeah, exactly. Because, they learned something, which is what we want them to do. Harry, do you have thoughts on that?
No, I think you outlined it very well.
That's funny. So that actually was kind of my next question, was the discussion in the article about having part of this be the results be due to the cumulative learning, which it sounds like is more around them not wanting to see this BPA. Do you think that was a chief driver of the improvement, or do you think there were other parts of the interventions that made an impact on the improvement?
Well, I think there's, the 2 parts. So with patients with urinary catheters, they were getting the BPA, but also the mandatory indication. So we tried to focus in two different ways in trying to get them to not order the urine culture in the first place. So I think with those two interventions, it really made people think twice about ordering the urine cultures, especially in patients with urinary catheters.
That's great.
Yeah, it is. And I'm wondering if the interventions for those patients with urinary catheters impacted the removal of urinary catheters earlier. So do you have any additional data on like catheter day usage post-study?
We don't, although that's a really excellent question in terms of if that was influenced at all. But that was not something that we looked at, but maybe in the future we will.
Yeah, interesting.
Yeah, it would be interesting to understand if that made the clinicians reassess the necessity of the catheter at that point, in addition to looking at the indication for a potential culture. We talked a little bit about this, but we know that many hospitals struggle with available resources for process improvement initiatives, and I'm just wondering what kind of resources were required to implement and monitor this initiative. And after, the initial measurement and the closure of, this particular project, have those interventions remained in place? And does anyone continue to monitor for improvements?
Sorry for the giggle. I think this kind of goes in line with what we were talking about before about being in the safety net, which is wonderful in a lot of ways, because I think it gave Mona and I just a lot of pause, and also really learning how to do the best we can with what we got. And if you take into the context of this in terms of the other sort of projects that we've done, when I sort of look through the numbers, I think we captured about 150 system-wide initiatives within the 3 years during COVID. When we started comparing to other institutions, for example, NYU and their value transformation, we realized that they had 11 project managers for one single hospital at Tisch, versus us, who had I think it was Mona and I and a med student that sort of worked with us for the stipend for a year, covering all the patient safety and value. And so you can see how much this prioritization, the focus on the high impact, and also just making sure that whatever we did, we were successful and meaningful in it. We looked through our projects. There was a 90% success rate there in terms of pre and post implementation. This is one of them. We wanted to make sure that the impact in terms of other things downstream was great. So we did a downstream sort of assessment if we could. And then just, whether they were sustained or also scaled across all 11 hospitals and not just in one unit or one hospital. And so that was very important for us. But yeah, the resources in terms of maintenance, there's not much. We have a wonderful data folks who were set up dashboards just internally for us to just peek at. But once it went, it tended to sustain, and we could sort of see that slope. And so we were very happy with it. And that's the way we want to do it.
Yeah. And like you mentioned, there are some resource limitations, downstream effects, and I wanted to talk about some of the limitations to the initiative and see if you could tell us what some of those were and how they might have impacted the outcomes, and, what the downstream effects were, maybe some unexpected downstream effects. Let's talk about those.
Yeah, it's interesting. I mean, part of the limitations that we mention is that we didn't do chart reviews to see if any downstream events would have decreased. So other interventions and other studies that have been published look at, when there's a decrease in urine cultures, there's a decrease in antibiotics and a decrease in length of stay. We didn't look at that, but it would be interesting to look and see if that happened with our study as well. I would imagine that we would see similar results with lower amounts of antibiotics.
Well, I'd just like to say thank you, both Dr. Krouss and Dr. Cho, for taking the time to talk about how you put science into practice. And I think this is really inspiring, and I think a lot of people out there could potentially also integrate this into their practice. Mm-hmm. Are there any other key elements that we didn't talk about that you wanted to highlight today from your study?
I think we covered
Yeah.
a lot. Harry, anything from you?
No, I think we covered a lot. I think the important thing was the concept of nudge and, making sure that we're higher impact, in terms of our interventions. The other thing that I think might be worth mentioning is, we had a council, that's dedicated for, overuse in particular. Asymptomatic bacteria urine cultures was one of them, but, amongst many other things. And so that council, we called it the High Value Care Council within the system. And so that sort of group in itself sort of brought in ideas, also set this precedence for, what is the norm in terms of reducing this unnecessary testing that was leading to harm. And so that I think other institutions can sort of adopt and have as a sort of a mainstay for other types of things.
Yeah, love it. Foley catheters and urinary cultures and all that. That's always going to be an initiative in hospitals that we're working on. So thank you guys so much for your research and sharing everything with us.
Yeah, thank you so much. And again, hospitalists rock. So
yes.
Thank you.
Thank you so much.
Thank you.
All right, bye guys.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AGIC scienceintopractice.org.